is still preparing.
Okay. Yes, we are live.
Right?
Yes. Good evening, everyone. Hope you're having a lovely week. And how was the weekend? For us, I think Saturdays for us are the busiest, and followed by, I think we get a little time on Sunday if we don't get any emergencies. So today we didn't have any emergencies. I think Dr. Vimy has to go again, but that's how the profession is. Saying that, good evening, everyone, and welcome to another session on Endo Crusaders. And this time we are going to talk about a topic which is supposed to be not very common, but I don't know. I mean, I think Dr. Vimy will be able to answer that much better. So way back in 2013, 14, when I was visiting my doctors with constant bloating and UTIs, recurrent UTIs, and food allergies, all I was told was I was having IBS. And recurrent UTIs, you can't explain why, but there must be some reason which the doctors were not able to identify even with all the investigations. So I was like taking medication for a very long time for the recurrent UTIs that I was having and the IBS, which never ended. But when in 2016, I ended up on the operation table, and they opened me up. My intestines were all inflamed, and there was adhesion all around that was there, and they had endometriotic lesions everywhere, right from my bowel to my bladder. Yes, it is as complicated as it can get. Endometriosis, one of the most underrated disease that is there all over the world. So as I tell everybody, every time we come on this platform, just to introduce what endometriosis is, it is a disease in which tissue resembling the endometrium or the lining of the uterus grows outside the uterus. So every time you bleed, that particular tissue also bleeds. But since it's not there in the uterus, there is no place it can go out. So it can cause a lot of inflammation and pain, and also fibrosis, because of which the organs stick with each other. So I had a frozen pelvis, and many women like me end up having frozen pelvis and a lot of other places where they have endometriosis. According to our data, endometriosis and interstitial cystitis are the most common causes of chronic pelvic pain in women. It actually estimates to 10% of referrals to gynecological practices, 12% of hysterectomies, and more than 40% of diagnostic laparoscopies. Endometriosis, a common cause of chronic pelvic pain, is diagnosed in up to 80% of patients. 80% is like a big, big number. So today, Dr. Vimy and I are going to discuss what exactly bladder endometriosis is. It was supposed to be very rare, but is it that rare really? Chalo, let's have a look. Hi, Vimy.
Hi, Shilpa. Hi, everyone. And as Shilpa said, Sunday is the time we get, and we love to spend with you guys. Absolutely. Every Sunday, whenever we get time, we just come here and want to talk about endometriosis.
Just making noise about it so that people know what it is.
Yes, true. Because most of the people don't know, as you said, so many laparoscopies and so many surgeries are being done. And most of them are like incomplete surgeries, or the diagnosis is not proper at the time of surgery. Suppose I go in and I was aware that there is only a ovarian cyst, but I find a bowel endometriosis or a bladder endometriosis, but I don't have my team ready to deal with it. Then you are stuck. And most of the cases this happens, and gynecologists who are operating in a standalone units where they don't have support of a multidisciplinary team, they abandon the surgery, or they do the surgery only on the ovaries and they come out. This is the reason that patients land up with multiple surgeries and their symptoms don't resolve. So it's very, very important that, and as you said, endometriosis affects all the organs. Yes, it is a multi-organ disease. It's a whole body disease actually.
Correct.
It
True.
causes fibrosis, inflammation, and it is affecting 1 in 10 women globally. So many women are suffering, and yes, with these, Shilpa, you won't believe it, these awareness programs, they are really coming out. At least they are asking for help, and now they understand, yes, painful periods are not normal. They should not live like that.
Finally.
Yes, some change.
It's taken a long time, but anyways, I'm glad.
Yeah.
So Vimi, tell our audience what exactly is bladder endometriosis and how can a bladder endometriosis occur?
Shilpa, I'm sharing my screen.
Yeah.
So bladder endometriosis, I'll just basically bladder endometriosis accounts for less than 1% of all the endometriosis. Wherein bladder is the most common. That's why we are discussing today.
True.
It is basically defined as endometriosis or endometrial-like tissue implanted in the bladder when it infiltrates the muscle tissue. The muscle of bladder is called as retrosal muscle. And it represents around 85% of the endometriosis of the urinary tract. For our viewers, I'll just brief what is a urinary system so that they understand what we are talking in a layman language. So urinary system is, we have two kidneys which help in filtering the proteins and other digestive material, and this is connected to two tube-like structure. These are called as ureters. These ureter basically carry the urine to the bladder, and from the urethra, which is like a meatus or a pinhole opening in the bladder. Bladder is a dome-shaped structure which can hold up to 400 ml of urine. Before you get the urge or you can't hold the urine, it's up to 400 ml it can hold. And from the urethra, the urine comes out. This is basically a urinary system. And this bladder lies just in front of the uterus. And the bowel, which we most commonly talk about bowel endometriosis in most of our talks, the bowel is behind the uterus. So there is a bladder, there is a uterus in between, there is a bowel at the back, and the ovaries and tubes are at the sides. Now, this is the how it affects different organs of the urinary tract system. So, bladder is the most common. It represents 85% of the endometriosis of the urinary tract system. So, 1% of the total endometriosis cases, out of those, bladder is. And second common is ureter. It is very important that ureter is identified and ureterolysis is done in all the endometriosis cases, because we may be dealing with ureteric endometriosis due to extrinsic endometriosis or intrinsic. Intrinsic is less common. Extrinsic means there is a compression outside, because as Shilpa also said that her pelvis was frozen. Frozen means everything is stuck to each other. So anatomy is distorted, and the endometriotic lesions put compression on the ureter. That is called as extrinsic endometriosis. So once we relieve the extrinsic endometriosis, ureteric function can be retained. But sometimes it may be causing a stricture in the ureter. Then the treatment varies, and we may have to go for a very advanced surgery for the ureteric reimplantation as well. Now, this is what I was describing. This is the bladder in front, then we have the uterus, and the bowels are behind. Most common site of bladder affection is the bladder base and the bladder dome. This is the dome area, and this is the bladder base. Here, this is the area where we find most of the endometriosis during laparoscopy or during our diagnostic workup for the patient. Now, this is basically when this is how it looks like when we do a laparoscopy. So this is the back of the uterus actually, and these are the ovaries. These are the black spots are the endometriotic lesions. So this is the side view of the abdomen actually. So this bladder, you can see this is a black area invading up to the muscle layer of the bladder as well. So this is the endometriosis of the bladder. And it can be associated with endometriosis of the uterus, peritoneum, bowel, and other areas. So basically, if you ask me how does it arise, there are different theories in literature, but Retrograde theory, we don't believe in that theory that the menstrual blood goes inside and causes endometriosis. This does not explain the endometriosis basically, but theory of mulleriasis does explain how it happens. It's basically a genetic evolution, or some stem cells are laid down which proliferate, and these cells produce their own estrogen. That's the reason medications don't work for the endometriosis, and excision only helps for all these lesions, which should be completely excised.
Makes sense. So a person who has endometriosis in the urinary system, the bladder endometriosis, how does it feel like? What are the main symptoms? And can it cause problems to the bladder?
Basically, this endometriosis, in general, I think symptoms we have discussed several times. It causes painful periods, fatigue, painful intercourse, painful urination, painful bowel movements, and associated symptoms like depression. Many other symptoms are there. So we will stick to the urinary symptoms of endometriosis. I would just describe how patient describe it. Some of the patients say that I feel like passing broken glass pieces. And they are also described as, they are also told that you have urinary tract infection, take these antibiotics and you'll be sorted out. So they always tell me I have UTI, but there is no bacteria. The cultures come negative because they don't have UTI. They are presenting because of endometriosis. They feel like that something is constantly pulling their urethra from where you pass urine. So they feel that there is some traction there all the time. A stinging sensation when they pass urine, difficult to describe. Sometimes they say that it rips them apart. When they have full bladder, they have sharp shooting pain. They tell us that they can't even describe. Sometimes they describe that something is moving or dancing inside. And there is UTI, but there is no UTI. So these are the descriptions usually patients give us when they come to us with the urinary symptoms. In majority of the cases, they're asymptomatic. They
True.
don't have symptoms. When a good imaging is done, which usually we recommend in all the cases, we can pick up many of these lesions. They have dysuria. Dysuria means painful urination. Like you have painful periods, when they pass urine, they have painful urination as well. Urinary frequency increases. If any lesion is inside the bladder, their capacity to hold the urine comes down. As I said, 350 to 400 ml of urine a bladder can hold when it is fully distended. When there is something already inside, definitely its capacity comes down. So it can hold little lesser urine. So you have to pass urine again and again. Urgency, you feel the urge to pass. Urinary tract infection, because sometimes you are not able to pass urine completely. There is a residual urine, and because of the residual urine, bacteria grows in that, and you have recurrent UTIs. Hematuria means passing of blood in the urine. That is also a very common complaint. Incontinence, sometimes you can't hold the urine, and overflow incontinence can be there. So these are the very, very common symptoms which most of the patients describe to us. And I would also like to say that if we look at the bladder endometriosis, which is 85% of the urinary tract endometriosis, out of those, 30% are completely asymptomatic, Shilpa.
Okay.
They don't even have any symptom.
Hmm.
They may not have any dysuria or anything. We just may diagnose them incidentally.
All
And
right.
20% are symptomatic. If we look at the ureteric endometriosis, asymptomatic are 65%. They'll not have symptoms. Symptomatic at 35%. But when they have very advanced disease, they become symptomatic, and by that time, the complete damage is done. So
Absolutely.
that this itself says that we should be more aggressive in diagnosing and treating them, because we also have come across patients who have lost their kidneys because of this, because their diagnosis was delayed, their ureters got hydroureteronephrosis, and kidney was completely damaged. And
That's
there are published reports that they had to completely remove the uh, nephrectomy was to be done to save the patient's life.
oh my God. That's like
Yeah.
crazy.
So that because there are huge percentage of them are asymptomatic, so it makes more reasonable and justified that we should diagnose them properly and treat them on time.
It can get messy. It can get really messy if not diagnosed on time. And Vimi, I was also reading up in literature. I think another cause of recurrent UTIs in people with endometriosis is also because of the lesions, the surface gets very rough. It's not as smooth as it should be. The lining gets interrupted, so there is scope of more bacteria getting accumulated in that particular area, and hence the recurrent UTIs. That's one
Yeah,
of the reasons for recurrent UTIs.
yeah, both the reasons are there. One is residual urine,
Exactly.
and second
Yeah,
is because of the damage of the mucosa, there will be more needles for infection. They can
absolutely.
implant themselves and they can grow there.
Absolutely. That's what I'm saying. It's so endometriosis overall is not as simple as it just is made to look like. It has a lot of things together. It's a complex disease. So a lot of things have to be looked into, before giving a verdict to the patient. So how many what kind of how many people, how many patients who come to you, maybe a percentage are with, are have bladder involvement?
Shilpa, sometimes the bladder involvement, there is superficial peritoneal endometriosis and there is deep endometriosis.
Hmm.
Now, deep endometriosis will have some lesions and it is easy to pick up.
Hmm.
So, when we image them, we send for imaging and ultrasound because our sonologist is highly trained and she can pick up those lesions. So, we don't find it incidentally, first of all.
Hmm.
Second is superficial peritoneal lesions are very easy to remove and they should be removed. There is no difference in the post-operative outcomes for those cases.
Hmm.
In our practice, same 1 to 2% of the cases we find urinary tract involvement
Hmm.
with general endometriosis cases.
Okay.
Bowel involvement is the most common. When we talk about extra pelvic endometriosis, first is the bowel involvement, and the second is comes the urinary tract endometriosis. So it accounts for around 1% of all our cases, and that bladder is the most commonly involved.
That's that's true. And diagnosis is uh, it has to be a trained radiologist. So what exactly is done to diagnose bladder endometriosis? Is there anything particular that the patient needs to look for? I mean, the patient has to tell the
Yeah.
doctor if they're not advising something.
Yeah. So first thing is we have to take a proper history.
Correct.
History of the patient is very, very important. And as bowel endometriosis is confused with IBS and some other disorders, same happens here. With the bladder endometriosis, it is often confused with overactive bladder, recurrent UTIs, interstitial cystitis. When anything that doesn't work or doesn't fit into the criteria, they are given a stamping of interstitial
Absolutely.
cystitis.
Absolutely.
Bladder CAs and chronic urethral syndrome. These are the most common syndromes where bladder endometriosis is often confused with.
Hmm.
And also sometimes they may have urinary symptoms, but they may not have urinary tract endometriosis.
Hmm.
Sometimes they may have huge cysts, like you can see in this photograph. These cysts are maybe adherent to the just bladder surface, and they pull on the bladder and they they increase the urinary frequency or they have painful urination, but actually they don't have any endometriotic lesions on the bladder.
Hmm.
Now, when it comes to diagnosis, as I said, medical history, most important part. Listen to your patient and then go ahead with the examination part. Now, physical examination, when we are looking at endometriosis, we have to look endometriosis everywhere, whether it is pelvic, extra pelvic. So our pelvic endometriosis involves complete bimanual examination, a speculum examination to rule out vaginal endometriosis, cervical inspection, and a bimanual examination for uterosacral endometriosis and for initial evaluation. Imaging, very, very important part. I'll just stick to the bladder endometriosis part. Ultrasound is the first line modality. Your good sonologist or a trained sonologist can pick up these lesions very well on ultrasound if it is done transvaginally. Now, if you say MRI is just a aided modality, not a first line treatment, and usually it is not needed in all of the cases. There is an IDEA group, where International Deep Endometriosis Analysis Group, which recommends a focused assessment of bladder and ureters. The lower third of the ureter can also be seen on a scan, and any strictures or dilatation of the ureter can also be noticed. Now, suppose somebody has to evaluate the ureters completely, then CT is the best modality.
Okay.
Okay. Otherwise, MRI for endometriosis is the next line of investigation when ultrasound is not giving us complete information. Second thing is when you have bladder endometriosis symptoms or anything, a trans-abdominal scan to evaluate your kidney, ureter, and bladder is also very important.
Hmm.
We have to look at the urinary system as a whole. We just cannot look at the pelvis and come out. Sometimes upper third, two-third of the ureter can be missed even on laparoscopy.
Okay.
When we are operating on the pelvis, we are dissecting the lower third of the ureter.
Hmm.
Okay, the upper third, two-third of the ureter, we are not dissecting and we might miss any of the abnormalities there. So a trans-abdominal ultrasound giving us the information about the KUB region, that is called as kidney, ureter, and bladder.
Correct.
It's very, very important. So for some cases, they may also need, as I said, MRI, and these are the ultrasound picture. This looks like a normal bladder, and these are the nodules which can be easily picked up on ultrasound. I don't think anybody should miss these such big lesions.
You have to have eyes to see those
Yeah.
lesions. You need to think about endometriosis to see the lesions.
Yes. Well, what your mind does not do, you cannot see. Always say in medicine.
Yeah, yeah,
So it
that's a fact.
holds true here as well.
That's a fact.
And MRI, as I said, it's a adjunct tool that can be considered as completing or supplementing transvaginal scan for an accurate pre-surgical staging. And some cases might also need cystourethropograph.
Hmm.
So they might need cystoscopy for even for diagnosis as well. So these are the diagnostic modalities which we use for urinary tract endometriosis.
All right. So, Vimi, if somebody has been diagnosed with endometriosis, bladder endometriosis to be precise, what is the treatment option that the patient has? And what if the patient decides not to go for the treatment?
See, as we already said that endometriosis causes fibrosis, inflammation, the tissues get, when we leave it untreated, definitely there is a lesion there. The fibrosis will cause further shrinkage of the bladder capacity. Definitely they are going to have more problems like dysuria, urinary frequency, and other issues.
Mm.
So if left untreated, bladder damage, ureteric damage, and kidney damage can happen. So that is a no if it is left untreated. Yes, many of the patients don't immediately agree for surgery, and we see it every day. So sometimes they don't have endometriosis in other parts, and they don't have any other symptoms other than that mild dysuria and recurrent UTIs.
Correct.
They really do not agree for the surgery. They are scared to get the surgery done for the bladder. So first line is surgery. Excision is the most important part of the endometriosis treatment. We have to remove it and suture it back. Not a very difficult surgery, but yes, a urologist should be there. So usually we do a combined approach. If it is a big lesion, we do cystoscopy by a urologist, and I do laparoscopy. So there is a technique in which we can cystoscopically we can mark those lesions and we can put the ureteric stenting. That is not mandatory, but in our practice we do that. We put two ureteric stenting, we mark the lesions laparoscopically, we excise that lesion and suture that defect in two layers. And usually it gives a very good watertight healing and patients do pretty well. Now, if somebody does not want to go for surgery, it's a difficult question. Uh, so, same treatment, what medical treatment is offered for other endometriosis is being offered, and that is the only way out if they don't want to go for surgery. So, there are progesterone only pills, oral contraceptive pills, and a newer drug called as Dynogest. And yes, their GnRH analog is quite prevalent. GnRH analogs has a lot of side effects. All of us know that. So if somebody does not want, in my practice, then I would prefer progesterone or a Dynogest or OCPs, but not GnRH analogs. So these are the therapies. If patient does not want surgery, these are offered cheaper.
Hmm.
But we recommend first line treatment as surgery, definitely.
Absolutely. I mean, you have to see, it's for all the patients who are going through endometriosis, please weigh your options and see what you think is right for you. It's a customized treatment for everyone. What suits me might not suit you. All right, like Dynogest, for example, like you just said, is something which suits a lot of people. But for me, Dynogest, created a mess out of me completely. I mean, I just went crazy. It played so terribly on my mind. So the thing is, talk with your doctor.
Yes,
Check
some of our patients also have.
exactly. So check what are the side effects of the medicines that you're eating. Just don't pop those pills. They seem like innocent little pills, but they can create a mess in your body. So trust me, surgery anytime is the first option. But if you're not going through it, please go read up, check with your doctors, go to the internet and read what all these medicines are and what you can expect from this, and then only take a decision. That's something which I've learned the hard way, but I think that's something which you need to do.
No, that's true. Some patients do not respond to Dynogest. Some patients do not respond to OCP. Some do have problems with all kind of drugs. No,
Absolutely.
see, always we talk about saying that patients' symptoms are being dismissed and there is a delay in diagnosis. They go to multiple doctors. But I must say that there is a set of patients also. When we give them the right advice,
They don't.
they try to find a doctor who will not suggest surgery. And what do I do?
I mean, that's what I'm saying. See, the problem is 4 out of 5 doctors will advise medical treatment for endometriosis. So
Correct.
it is actually speaking, it might not be the patient's fault also. It is the problem with the awareness, both with the doctors and with the patients. If the
Yes,
doctor is not confident enough of doing something like a surgery for endometriosis, they would not recommend.
I know.
Right? It's simple. And when they don't recommend, patients feel like, okay, four doctors are saying that medicines will cure me. Why will I go for a surgery in the first place? You know?
So I think the doctor is trying to push me for surgery unnecessarily. That's what
Exactly.
I'm saying. See, because I am an excision surgeon and I recommend surgery. So I do find a set of patients who is looking for doctors who will recommend medicines.
Absolutely. Absolutely. Because surgery is never a first choice for patients, most of
Hmm,
them, you know?
I know.
That's the reason I was asking this. So after the surgery, once the surgery is done, I know it's not a very simple surgery. There are complications that might happen in a bladder surgery. So what is it that I can expect post surgery, the goods and the bads?
See, Shilpa, post-operative care is almost same as any other endometriosis surgery. If it is a superficial lesion, like any endometriotic lesion, which is shown in this picture, is a superficial, some blebs are there, and we are just excise them. We don't give any special care in terms of the endometriosis excise. But if it is a deep lesion where a detrusor muscle is involved, as you can see in the second picture, where Foley's bulb is seen,
Hmm.
so where is a partial cystectomy done or a complete excision of that lesion is done, and we suture the bladder in 2 layers. There is a need for Foley's catheterization for 10 days to 2 weeks. So different doctors have different protocols. So you can follow for 10 days or 2 weeks. We put a silicone catheter and we send the patient home with the catheter.
Okay.
So they can be discharged depending on the surgery done, either in 1 day or 2 day, and we send them with the Foley's catheter because that bladder suture has to heal well. So this is the only special precaution they have to take. And yes, we give a cover of antibiotics so that the infection does not happen because they're catheterized for a longer term.
True.
Other than this, usually there is no special post-operative precautions or special post-operative things to be done in cases of bladder endometriosis. This works very well for most of our patients. And during surgery, when after suturing, we do check for any leaks or any problem with the suture line. So we put a dye and inflate the bladder, and we check for the whether it is a watertight compartment or not. So most of these cases, healing is very well.
All right. So To all our viewers, surgery is not that bad. So you can think about it. If you are having symptoms, think about it.
It's not that bad.
Yeah, it's not that bad. So rather than going for a hysterectomy which I went through, which was supposed to be 1.5, 2 hour surgery and lasted for some 6 hours, I think, rather than going through shocks, might as well go through some kind of a excision surgery, which might help you, if diagnosed early, which might prevent hysterectomy from happening. For me, I think there were a lot of other issues for which I had to go for it. But what I feel is diagnosis is the first step. If you are diagnosed on time, there is a very high possibility that you will be able to lead a better quality of life. But I'm saying that endo cannot be completely cured, as we have been saying this every time, but it can be managed. The symptoms can be managed. Surgery and removal of endometriosis tissue is the gold standard when it comes to endo. So, Vimi, we had a lovely session. I think this was something which was due for a long time.
Yeah, bladder endometriosis we never
Yeah,
discussed
we
because most
haven't
of the time
discussed.
it either stays to the ovaries or the bowel. So
Absolutely.
because extra pelvic endometriosis is not so rare, so we should discuss about it so that more patients are aware of it and they come forward with their complaints.
Exactly, exactly. So, if you have anything similar happening to you, please check with your doctor. For me, monitoring my endometriosis has become like a way of life. I keep a check on everything that I do, what's helping me, what's not helping me, and everything. So, for us, what I would like to ask our viewers is, if you have something specific that has helped you with your endo, I would love you to put that in comments so that it helps rest of the viewers also who have been going through tough time with the endo. It's a community, it's a family. I think this is something which we need to do for each other. For rest of the things, the doctors are there, right with me?
I know.
Yeah. Perfect. Are there any questions? Yes, I think Anu has asked, Doctor, for how long a patient can take Dynogest?
It depends. Your doctor has to decide. It can be given for a longer term also. We start with 3 months therapy and then we can extend even for 2, 3 years as well. But yes, your doctor has to decide how long the therapy will be given.
Correct.
So every patient has different requirements and there is a different protocols followed by the doctors as well in terms of medication. So your doctor is your best judge to decide how long they can give you the Dynogest.
Absolutely. So glad we had this session, and I'm so happy to do this session once again. Thank you, Vimi. It was like a pleasure again doing this with you.
Yeah, thank you, Shilpa. It's
And
always
thanks,
a pleasure to be with you and talk about endometriosis.
absolutely. And